Welcome to the Smart OB Med curriculum. Social media for advancing residency training in obstetric medicine. We here present to you a national collaboration between the Universities of Ottawa and Alberta. This research project has been generously funded by the Department of Medicine at the Montfort Hospital, empowering future physicians in the care of medically complex pregnancies. We hope you will enjoy it.
We present to you our first module. In this session, we'll explore the basics of caring for women with medical conditions during pregnancy. Women with medical conditions are often sexually active and can become pregnant. Always discuss contraception, especially with women of reproductive age who are prescribed potentially teratogenic medications. Offer preconception counseling when possible. Instead of simply advising women not to get pregnant, discuss the specific risks and implications. Very few conditions are absolute contraindications to pregnancy, but women must be informed of their risks. Many procedures and medications are safe during pregnancy. If one is contraindicated, alternatives typically exist. When unsure, consult trusted resources or clinical experts. Pregnancy alters physiology but is not a pathological state. Avoid treating pregnant patients as if they are inherently ill. We'll now review the physiological changes in pregnancy, focusing on cardiac, pulmonary, renal, gastrointestinal, hematologic, and endocrine systems. Cardiac output increases by 30 to 50%, and blood volume rises, essentially creating a state of volume overload. Systemic vascular resistance drops due to the progesterone's effect on smooth muscle. Also, remember the hemodynamic impact of the gravid uterus when the patient is supine, with compression of the IVC potentially affecting preload to the right heart. Progesterone drives a normal physiologic hyperventilation. Oxygen demands increase, leading to higher PaO2, and given the hyperventilatory drive, PaCO2 levels will drop in pregnant women. Glomerular filtration rate and renal blood flow increase. Progesterone causes dilation and urinary stasis. This lowers urea and creatinine levels, so even small increases may indicate renal injury. Proteinuria and glucosuria are also common and may be normal in pregnancy. Acid reflux is nearly universal due to reduced lower esophageal sphincter tone and delayed gastric emptying. Additionally, placental production of alkaline phosphatase leads to elevated serum ALP levels. A mild leukocytosis, often neutrophil predominant, is normal and not necessarily a sign of infection. It reflects a demargination effect similar to that caused by stress or steroids. Dilutional anemia is common due to disproportionate plasma expansion. Hemoglobin thresholds vary by trimester and in the postpartum period. Platelets can gradually decline in the third trimester, often staying above 100,000, termed gestational thrombocytopenia. Pregnancy induces a hypercoagulable state. Clotting factors increase while fibrinolysis decreases, raising the risk of thrombosis. Pregnancy is marked by insulin resistance and relative glucose intolerance. Glucose intolerance tends to worsen as pregnancy progresses, while fasting hypoglycemia becomes more common. Vaginal delivery is generally safer than cesarean sections, even for women with medical conditions. Cesarean sections increase fluid shifts, blood loss, and thrombosis risks, and should be reserved for obstetric indications. Maternal and fetal health are typically aligned. While conflicts can arise, maternal well-being usually supports fetal well-being. As the saying goes, healthy mom, healthy baby. Many pregnant women are hesitant to take medications. Clearly explain both the risks of the medication and the risks of not taking the medications. This will support adherence. Folic acid should be started preconception. Pregnancy drug categories are less helpful than a careful risk-benefit assessment. We have therefore moved away from the prior letter-grade FDA categories. Some drugs, like ACE inhibitors, tetracyclines, and quinolones, are rarely appropriate. When prescribing, ask yourself the following 4 questions. Is pharmacologic therapy necessary, or are there non-drug options? For example, have non-pharmacologic preventative treatments been used for migraines, such as lifestyle management with heat, massage, sleep, hydration, regular meals? The second question is, what are the risks of not treating? For example, not taking pseudoephedrine during a viral respiratory infection will cause some discomfort, but no harm, and the viral illness is temporary. In contrast, stopping anti-seizure medications can have severe consequences when a seizure leads to fetal hypoxia and acidosis, as well as putting the pregnant woman in danger. The benefits of treatment of seizure disorder outweighs the risks, and medications with lower teratogenicity can be chosen. Once you have decided that treatment is necessary, what safety data exists for this drug? The baseline major malformation risk is 3% in the general population. Preconception counseling should cover how medications impact pregnancy and whether they can be safely continued or not. Discourage over-the-counter medication use without physician input. For instance, NSAIDs are safe early but risky later in pregnancy. In general, we favor older, well-studied drugs with long-term data over newer ones with limited surveillance. And lastly, does the dosage need adjusting due to pregnancy-related changes? Absorption may slow due to reduced gastrointestinal motility. Increased plasma volume and fat alter volumes of distribution. Reduced protein levels increase free drug concentrations, especially important for protein-bound drugs like anticonvulsants. Renal and hepatic clearance also increase, affecting dosing. Reliable sources include Reprotux. If you are a learner, you can email Reprotux at reprotux.org to request a free access. Other reliable sources include Terrace, Micromedics, Shepherds, and Reprotex, as well as Mother to Baby. Mother to Baby offers easy-to-read fact sheets for patients, which can be quite handy. LactMed is available on the internet. The MedsMilk access is only available to those using Alberta Health Services computers. Most imaging are well below the fetal radiation ceiling of 50 milligray or more. Of note, it takes radiation levels of 50 milligray or more to slightly increase the risks of childhood cancers such as leukemia. This table indicates the approximate radiation exposure to the fetus by imaging modality and should serve to reassure you that when indicated, these tests should not be withheld because of pregnancy. We hope that you've enjoyed this module and found it useful to start your learning journey in the care of pregnant women with medical issues.